right, welcome back. We're picking up right where we left off, continuing our discussion on Bill 60. Now, here's the key question. Why go down this route instead of simply pumping more money into the public system because we know there's space available in operating rooms, Dr. Ho?
I think we can agree that these surgical clinics in the community can be a good idea, but there's no reason why they have to be for-profit. They can be connected to the hospitals, they can operate on a not-for-profit basis and do the exact same thing. And to Dr. Watley's point earlier about unlawful billing and about these issues in for-profit clinics. We've seen evidence of this in BC, in Alberta, in Quebec, of for-profit clinics billing unlawfully in order to make more money. And in BC, we probably all heard about the recent Canby case that went to the BC Supreme Court, the BC Court of Appeals, and then went to the Supreme Court of Canada, where they declined to hear the case. It all stemmed from the fact that this private for-profit surgical clinic was unlawfully billing and was to the tune of several hundred millions of dollars from the BC government. What the judge found in those courts were that private for-profit delivery of healthcare resulted in duplicative billing.
The other issue, I suppose, would be that maybe the cost of some of these procedures could be more expensive. So in Quebec, for example, they found that a colonoscopy in a private facility cost just over $700. In the public facility, it was $290. Now, hypothetically, if we were to witness a similar cost disparity here in Ontario with some of these things. And again, I'm not saying that we necessarily would. It's possible the government could control for that, but what would be really the practical consequences of something like that?
Well, I think if we look beyond the financial costs, look at what is happening currently with respect to colonoscopies, cataract surgeries, some joint replacements that are starting in for-profit clinics in Ontario. What we see is those who are medically complex, those who are most vulnerable, are being placed in the public system or in our public hospitals and remain on these long wait lists, whereas those who are either wealthy enough or are not medically complex, are not vulnerable, are seen ahead more expeditiously in these private clinics.
Well, why would that happen? Because there's a wait list, and presumably it's the medical staff who are going to be deciding where people get these procedures.
I mean, I don't think it's outright discrimination, but it happens because what happens is they look at the case and they say, well, this patient is really complex. They need more service. We can't actually service them appropriately in our setting because we don't have the type of facilities that are available in a hospital. So I've seen this time and again actually with colonoscopies and patients that I refer, for example, for colonoscopies. So patients who are healthy and actually don't have any other conditions, whether they be physical or mental health conditions, are able to often be seen at independent health facilities, whereas patients who have complexity and actually are some of the most needy in terms of needing the tests are not able to get that same test. And then ultimately we talked about this Alberta report that came out from Alberta just this last week. And the goal here is actually to reduce wait times for the public. And what we saw in Alberta is that overall didn't happen relative to other provinces.
Dr. Watley.
So with respect to the sickest patients, our system is built on the presupposition that our sickest patients go to the highest level of hospital. So we have tertiary level hospitals associated with the universities in downtown Toronto. Community hospitals, when they find a patient who has a problem that they can't fix, they send them to the tertiary care hospitals. When we have a problem in my doctor's office, my own personal clinic, when I can't fix something, I send them to Emerge or I send them to a consultant. This is the basis of our system. So to say that there's something nefarious in people getting patients to the proper place where they need the level of care that they require is duplicitous. You asked a very good question though earlier, Marissa, when you said, what are we achieving? And what we're achieving here, and I'm not sure it was even done by intention, is we are achieving activity-based funding. So for the last 20 years, Quebec and Ontario especially have tried to move hospitals away from a global budget basis of funding. What that means is the hospital gets a mountain of money and they're told, don't run out of money, whatever you do, as opposed to saying, hey, you need to provide good care and lots of care for everybody in your community, or you won't get paid for care. So the rest of the world has gone away from global budgets. towards activity-based funding. Hospitals in Ontario and Quebec have found all the reasons why activity-based funding or patient-based funding is a bad idea. These are the ways it can fail. Independent health facilities allow us to get to free management up to try to innovate on patient flow processes so that people can get the x-rays they need, they can get the MRIs they need, they can get the eye surgery they need. That's the moral high ground in this discussion, not protecting the heavily unionized environment in public hospitals.
All right, we'll have to leave it there. Up next, a fresh initiative tackles Ontario's primary healthcare system for effective solutions. Stay tuned.